Okay, well, good afternoon and welcome to Digital Strategies to Foster Family Engagement in Addiction and Mental Health Support. I'm Gail Cormier, the Project Director of NASDAQ, the Family Center of Excellence. Before we start our presentation today, I would like to go over a few housekeeping items. Today's webinar is being recorded. The recording, along with the PowerPoint presentation slides and any additional resources, will be uploaded on our events page after the presentation. All attendees will be muted for the presentation portion of today's webinar. However, we still look forward to hearing your questions, and we're happy to help you with any technical issues. To ask a question or request technical assistance, please send a message in the chat box. We'll be watching the chat box during the entire presentation. If time allows, we will unmute and you will have an opportunity to ask your questions. You can also use your raise your hand button. When you leave this webinar, you will be redirected to complete a short feedback survey using the link provided. This survey will help us continuously improve our webinars, and it also fulfills our SAMHSA funding obligation to provide them with important data required by our contract. Please note, all information will be confidential and we will respect your privacy. We do not offer CEU credits for our webinars, but you will receive a certificate of attendance immediately after you fill out the survey. What will happen is you will exit our presentation and it'll bring you right to the survey, and when you finish the survey you will get your certificate. I would like to thank SAMHSA for allowing us to share this information with you today, and again, thank you for joining us. It is now my honor to turn this webinar over to our NASDAQ partners from the Partnership to End Addiction, and they will introduce themselves. Molly, Fred?
Thank you so much, Gail and Lachelle and the entire team. A lot of gratitude being a part of this amazing Family Center of Excellence and the Federation team. Very briefly, I'll introduce myself and Molly, then we'll dive into the presentation on using digital strategies to engage families and to see how we can expand the reach and access of family-based support to those most in need. So very briefly, my name is Fred Munch. I'm president of the partnership. I'm a clinical psychologist. I'm a person in recovery from heroin addiction, and I'm a believer in the opportunities that technology brings to engage people in the process, and how we can build hybrid models of care. Molly?
Thanks, Fred. I'll echo your excitement to be here today with all of you from all the places that you're coming from, and feeling grateful to be in collaboration with Gail and Lachelle and the NIFSTAC team, NIFSTAC family. I am a licensed clinical social worker by training. The work that I do at Partnership aims to make family-focused care more accessible to treatment providers, more sustainable for treatment providers, more exciting for treatment providers. In addition to the work I do at the Partnership, I am a therapist in private practice, working mostly with families and couples, and teach family therapy at a place in New York City called the Ackerman Institute. I'm also a member of a family that has been meaningfully impacted by substance use and mental health challenges. So those are part of the lenses that I bring to our conversation today.
Thanks so much, Molly. And when you have questions about family treatment, and you're asking Molly, so we'll be clear about that. Technology, you can come to me. Echoing something Molly said, and in terms of the partnership, I also want to thank our partnership, the Partnership to End Addiction family. They're the people that Molly and I work with, do such amazing work. And I'm briefly going to go over it. I'm sure if you've been on other webinars, you've heard more about our services. but the advocacy and the work we do. And we exist, we're the merger of the National Center on Addiction and Substance Abuse and the Partnership for Drug-Free Kids. And we came together so we could have more impact. And that our 4 primary areas are in empowering families through our direct services. And I'll be going into a little detail about some of those services, the digital services. As a national organization, our services are overwhelmingly digital and or remote-based services. We also focus on advancing effective care, and that's some of what Molly's work is on in terms of the technical assistance and empowering providers and community-based leaders to integrate family therapy techniques, but also doing cutting edge research with our colleagues at the partnership who are part of sort of the, different recovery networks, the NIDA Family Recovery through network through Aaron Hogue and his team, as well as a number of other groups where we're doing research on advancing effective care, particularly for families. Shaping public policy and advocacy is a big part of what we do. So to get dollars available for direct service providers who are doing family work, for example, parity work, ensuring that there's access to medications for addictions treatment, and a number of other things, as well as changing culture. And many of you know us in terms of some of the work we've done as the partnership. Prior to this, in terms of the ads we do, we're very heavily family focused now. The goal is to empower family members to be a part of the solution. Next slide. Nothing much more to be said here, but the caregiver and family is the focus of what we do. And then around that, we've built our network, and the goal here is to partner, whether it's with the Federation or other groups, to expand the reach of services so families are part of the equation. And that's something Molly and I will be discussing, which is families are often left out of the equation, and digital is an opportunity for us to really empower and bring people into the conversation. Next slide. So families, this is a very basic slide. And by the way, there's references at the end of this presentation, particularly on digital support. Our goal is not, one of the things I want to highlight, our goal is not to highlight the power of family-based therapies. You're all here, we're all part of this family, the Center of Excellence, and you've seen many presentations on this. It's really how we can leverage digital to then expand the role and ensure that families who may have had barriers are not connected. But families often are the most motivated to help their loved ones. They're in it, right? So they're the first responders if given opportunities on the journey. Family members, particularly early on, and we know this from the research, have significant influence. But the other part is when other options have been exhausted, families are very often the last people who are there. And when family members are trained to understand the difference between intervening and letting go of the outcome or just letting go, we can empower them to be more engaged. And then we want to highlight one thing, that family members can be engaged, but it's often not on their radars, whether that's through old antiquated models of, you just got to let go and that's it, or there's many barriers, and that's one of the things we'll be discussing. Next slide. In terms of our family intervention targets, it's all here: the entire family, a subset, a couple, or concerned significant others. Concerned significant other can be a parent, that's mostly who we are, but it can be anybody. It can be a partner, it can be a friend, it can be a grandparent. 10% of the people calling our helpline are grandparents, 8% are siblings. So it can be any concerned other who wants to support someone through a mental health or addiction challenge. Next slide. Molly, gonna jump in here and take over this part.
Sure, thanks, Brad. So one of the things that when we're meeting on this individual family level that we often ask when families are speaking about their goals or their hopes is, what's getting in the way? What's getting in the way of this thing that you're wanting as a family? What's getting in the way of your family or an individual in your family meeting the needs that they have or achieving a goal? And so when we're thinking about this goal that we all have, as Fred is saying, we're all here because we believe in the power of families. When we're thinking about what's getting in the way for them to be meaningfully engaged in services, we can look to some of the research on barriers, and we understand that there is a lot of meaningful research about what gets in the way of families being meaningfully involved in the care of a young person and their family. Sometimes we talk about those barriers as being kind of logistical barriers or relational barriers. And sometimes we can also think about them as barriers that exist on the individual family level and then on a systemic level. And so just starting with talking about the barriers that exist on the individual family level, my assumption is that many of the folks on the call will resonate with several of these as being a factor, something that got in the way or that can potentially get in the way, again, of being effectively involved in the care of a loved one. Some of these I'll just name briefly, thinking about travel, the location of services, time, scheduling of appointments, particularly when you're talking about working with a whole family. Coordinating schedules can be really challenging. Thinking about lack of resources to make treatment possible. Thinking about the impact of prejudice and discrimination. We can think about stigma as a relational concept, as something that is so wound up in systems of oppression. How does that get in the way of families being invited, being meaningfully involved in treatment? Participating in treatment requiring vulnerability. Having experiences in treatment in which families felt blamed. Certainly in my experience gets in the way of families feeling prepared to engage in another treatment experience. One member of the family or more than one member of the family struggling to feel engaged and that having an impact on others. Conflict with their family. All families have difficulties. We understand that conflict and discord within a family can get in the way of them being meaningfully engaged in a treatment experience. Unhelpful prior experiences in therapy is something that emerges all the time. And that, of course, we can understand, right? If I tried this before and I didn't find it helpful, it's going to be pretty challenging for me to imagine trying it again. Somebody not understanding or not having access to information about how effective relational therapies can be, and coming from a premise that individual therapy is going to be the most effective approach for the person that I care for. Hoping that things might work themselves out. Sometimes they do, but a belief that things might work themselves out without participating in treatment. And then also not being as aware or in touch with their power, the impact that they can have being involved in treatment. So probably one or many of these are a factor for families that are struggling to engage in the treatment process for their loved one with a mental health or substance use difficulty. And we can go to the next slide. So one of the things that's important to me and to us, I think here, is moving beyond just talking about the family level barriers and talking about systemic barriers. What gets in the way that don't have anything to do with an individual family's experience, what's happening for those individuals within that family or within that specific family ecosystem, and really thinking about on a systems level, what shapes families' difficulties in being meaningfully engaged in treatment processes. Not to diminish or minimize the barriers that I just named, but really just to highlight, let's look at these systemic forces. The first here being organizational expertise. We do a lot of work at the partnership, as Fred mentioned, where we are wanting to support more family-focused treatment, a different attitude towards families. And we understand that organizations are where they are, and we want to meet them where they are, but attitudes towards families that are unhelpful, feeling ill-equipped, feeling de-skilled is often a feature that shapes organizations when it comes to engaging family members meaningfully. Clinician scheduling, we understand that when we're talking about a mental health or substance use crisis that we're all facing, we're all involved with in different ways, that clinicians being overscheduled, overburdened, administratively and clinically is a huge factor to meaningfully engaging families. I can see two clients, or I can try to make a 30-minute phone call to invite someone to come to treatment. And we know what the system is going to suggest that I do. The third feature here that's a systemic issue is that billing systems, regulation systems do not often reward family engagement. Family therapy is time intensive, involving family members is time intensive. thinking about ways to have a treatment for concerned significant others without their loved one present is especially challenging. If we want to bill under a patient's chart, but the patient's not going to be there, all of these things create real difficulties in doing this kind of work that we understand to be valuable. Another system barrier that's important to recognize is that, and especially when we're talking about kind of white Western medical culture, the unit of intervention is the individual. The diagnosis is at the individual level. This way of thinking about pathology, thinking about what needs to be quote unquote fixed, does not necessarily invite thinking about the client as the family rather than the individual, thinking about the client's family as having resources rather than just imagining more pathology there. And that certainly gets in the way. And then, not necessarily understanding how important concerned significant others can be in care. So spending the time that we are on this is important to us, or important, because when we're thinking about wanting to move this needle and think about how we can use digital interventions, use telehealth to think meaningfully about how to prioritize family engagement, we're thinking systemically, we're working systemically, we're thinking about relationships, right? Problems don't exist within people, but between people and larger systems. And if we focus too much on individual family barriers, we're holding these individuals responsible rather than systems. Someone put in the chat about accountability. And for me, focusing on system barriers is holding systems accountable rather than individuals. If we're wanting to transform the way that services are approach families, if we want to think about how we can use these digital tools to engage families more meaningfully, it's my belief that we need to focus on these systemic barriers rather than focusing on what's getting in the way for one individual family. So we can go to the next slide.
Thanks, Molly. I'm going to remove spotlight. Can y'all hear me, Molly? I can only see you. Can you hear me?
I can, yeah.
Okay, wonderful, wonderful. So as all of you know, there was a massive shift in how people saw care due to the necessity of staying safe during COVID-19. And there was a significant increase, monumental increase in telehealth services. And that has, now this is an older slide, is over a year old. It's waned a little more, but we're still at around the 30% mark. The last I saw, 3,000 times, 30 times mark. Whereas the system has changed. And so whereas something was, people were fearful of, people did not believe in the power of it, they saw it could work. And next slide. And where they saw it could work is, in terms of certain specialties. And if you look at where we saw these significant increases and where it's staying is in psychiatry, mental health, psychology, and substance use disorder treatment. It's not even a race here. And part of the reason is because digital is a way to leverage the strengths and the opportunities set forth by the digital sets forth opportunities to intervene. So some of the mechanisms that keep people away, some of the mechanisms that keep marginalized groups away, we can overcome with digital. Next slide. So when we think about digital, there's a lot of good and there's a lot of bad. But when we think of some of the good, there's unquestionably the opportunity for reach access. And we talked about that in terms of barriers to family-based therapies. There is no question. So when we look at the mobile phone, right, there used to be, if you went back 20 years and you said reach access, yes, it was great, but it was great for people with internet access. It was great for white people, wealthy people, industrialized nations with internet access. If you back up now and then you go to the mobile phone, that used to be called the digital divide. Right. That does not exist anymore. And in fact, you could even argue it's completely, if you look at text messaging, for example, or even you look at just general mobile phone use, there's none whatsoever across race, across ethnicity, the only play across socioeconomic status. The only place you see it is age, which is not trivial. And, you know, I want to highlight that we need to make sure that we're engaging adults over 65. It's turning into adults over 75 now because of the shift, but it's not trivial in terms of that. But what we really see is you know, digital-based therapies, right? Whether it's telehealth, but also phone-based therapies, text-based therapies, they allow for someone to feel safe. And there's years of research, 50 years of research to show that people disclose more and disclose much quicker over digital mediums than in person. And part of that is the research, when you look at the mechanisms, because there's not necessarily a fear of judgment. There's some distance so you can say something. The other good is the continuance, the salience of care. We know that treatment is not an episode, but a journey. Personalization, analytics to predict. This is a great opportunity for us to personalize care. We'll go into some of the work we do to personalize care and highlight the opportunity to use data to then drive personalized care. This can be at the individual level. This can be at the family level. This can be based on demographic factors that we can personalize care to. But all of these things in terms of the personalization, which is if you have a network of 50 therapists, and you can personalize not only to needs, target, psychiatric addiction target, you can target to preferred gender, sexual orientation, gender identity, race, ethnicity. All of these things become easier via digital, so people are more engaged. You also get an environmental view very often of the individual, and then you get just-in-time environmental view of the individual's world. You know, you can ask someone to take a picture of the world. If you have a telehealth session, you could see in someone's house. There's just-in-time and timing, and this is something Molly talked about, and then it is location agnostic. In terms of some of the concerns, dehumanization is real, right? People feeling disconnected from other people, staying in their house, not getting outside. This is a real concern that we have to stay on top of. And we have to, whether it's localizing people to get out in their community and to a local community group or bringing people in, we have to be clear about. Substitution is a derivative of that, which is, oh, this is just as good as in person. Nope, it's different. So pretending that this is a substitution is really important. The other ones I'll skip going through all these because we talked about, and I want to get more into, and I'm looking at the time, and I know we want to leave at least 10 minutes for questions. So, but privacy and security is something that certainly want to highlight, which is, remember, when someone comes in through a digital engagement, there is a digital breadcrumb. And if it's privacy and security are not paramount, and you don't have a HIPAA compliant server, and your people are selling data, I don't know if some people saw, there was where one of the nonprofits was selling their data back to Facebook. In terms of like, this is not, and like, oh, but we want to hyper target and target those people more. Well, that is not okay. So you just have to be mindful of the power of technology, and just being mindful that we should not be, we should take privacy very seriously. So I'm gonna, can you click on it one more time, Lachelle? Yeah, so I just want to highlight one thing, which is as we move forward, technology, for technology's sake, I started this slide, by the way, with personal narratives, and then the printing press. But instead I couldn't fit it, so with TV. But like, look at these, look at what it does. Dive back into this later. Each type of technology adds an opportunity, whether it's from the family side, the individual side, or whatever that might be. But as we think of technology, think of what we're hoping to capture, and then looking at the opportunity for these technologies. Next slide. Can you, one more time, Lachelle? Sorry. Yeah, great. So, highlighting what these mediums and modes offer, and and to intervene based on how we live. And this is one of the most important opportunities that technology brings, which is a hybrid model of care. It is not one is better than the other. It's not that digital is the end all be all. It's that we now have these opportunities that we never had, and we do it based on how people live. Our lives are continuous. However, there are episodic moments of clarity that really mean a lot. Same with therapy. There's synchronous and asynchronous communication. That's synchronous with an individual therapist or person or peer, whatever that might be, is one way, but we all engage in asynchronous therapies, automated and human. Automated therapies are very powerful in terms of developing personalized intervention that can be sent out for massive, massive scale. We just finished a text messaging study that was 100% automated, and it reduced drinking, heavy drinking in individuals from 27 drinks a week to 13 drinks a week. So an automated intervention can be powerful to build salience. But there's human, so we have active and passive. So it's passively getting a text message, for example. As you can tell, I'm really love text messaging, and you'll see again later, but there's also active, captured, and ephemeral. It's really powerful to have an anonymous survey that doesn't collect an IP address. Just like you can call a phone line anonymously, you block your phone number and call a phone line and nobody knows ever, and you're having that conversation. And then there's the individual in the group. We can bring groups together very, very easily, and that includes families. Next slide. So when we think of these opportunities, and as Molly and I were chatting, I think the point is we've gotten the point as to what digital can do. So I'm not going to spend too much time on this, but coordinating multiple schedules can be done because people are all over. You can do it during lunch now at work by going outside on your phone. Well, there's someone in California, someone in Florida, someone in New York. You can have, coordinate schedules through, a doodle poll or a Calendly. You can have asynchronous communication where, well, let's say you can't make it. Well, someone can see a record of that communication and connect. So you're bringing the family in a different way with coordinating using technology as the medium. And that medium is about connection. It's about transparency. It's about showing people that they can connect in different ways. And then you're adding that people might feel increased opportunity for disclosure and reduction in stigma and feeling less judged when they're doing it remotely. This is a great opportunity. And one of the things Molly mentioned earlier is that people have different reasons, and everyone on this call has seen all the different reasons. So you can mix and match, right? You can think about what works for person A versus person B. You can think about someone who's incredibly afraid to open up. So can you use a text-based medium where someone feels safer? Can you reach the concerned other, like a parent, and the child separately through text-based communications, but you're asking the same questions and you're bringing this in so the therapist has more opportunity to really understand an unbiased judgment from each of the parent and the child, for example. I mentioned the treatment in the setting, the home, really video chat, welcoming you into your home. That's new. That's also scary for people. So you're even creating more sort of vulnerability in a good way, though. Are you going to invite me into your home? And then, as I mentioned, these multiple opportunities for connection that we really shouldn't discount. And the one thing I want to highlight here is that there is no special system or right way. Your mobile phone and a computer can do a lot. You don't need much to make this happen. Next slide. So one of the things we want to highlight is there's a few different components to it. There's automated self-guided programs, and there's human supported programs, and there's hybrid programs of these. If you look at most of the parent-based CSO focused sort of true digital technologies, they're like courses, they're learning driven, guided parenting programs. They are automated, and they may have a human component, supportive accountability component where you're mixing, but very often they're skills acquisitions based, and it's really focused on communication skills and then many other things. There are some for the whole families, but very few, much more for the CSO and parent in terms of this. A lot of it also is for younger children, but there's more and more, including what we're doing, including what the Federation is doing for family members of with older children. And there's also automated messaging as well. And so one of the things, I love this model, and Triple P is a great program. If you've never seen it, it's one of the original digital parenting programs. As you can see, this is a 2014 article, and it was a review and meta-analysis of everything that was done. They've done a great job, but they highlight, yeah, this sort of like intensity, we can teach people about communication strategies, but at the highest level, we have this intensive family intervention that we can do digitally, and being mindful of all that and bringing the entire family in. Next slide. So this is just very brief. This is specifically about targeting disruptive childhood behaviors in children under 9 or over 11. And some of it was a clinical and non-clinical range. You can go and look at this. This is our colleague Amit, who has helped us prepare this and was part of the presentation, who did this review. And yes, we'll certainly, I just saw something pop up about the link for the slides, of course. But as you can see, the effect sizes are real. There is the power of interventions are real. Now it wanes the older kids get, and that's important to know that, and that's a very concerned significant other parent intervention. When people are younger, there's more of an influence. So the more influence you have over someone, the more likely you will be able to make a change. However, if we look at some of the craft literature, for example, or some of the family-based intervention literature, that in terms of mental health and SUD, we really see that there's a powerful effect as well, particularly in terms of motivating someone to get them into treatment, and then when they're in the treatment, having a family focus. All right, next slide. There's no shortage of digital parent training programs. Like, that's what I'll say. SAMHSA has Talk, they hear you, it's an app. It was not so great. Now it's really good. They've done a great job optimizing this. They have a podcast now as well. There's the Triple P program. You go on, Coursera and all of these things, and you can pay for parenting courses. And it really ranges in terms of what's available. So all you have to do is search. We are not endorsing any programs, just like the Federation is not endorsing. Next slide. Both the Federation and the partnership have skills building courses. One is on self-care and action planning, through the Federation of family members and for their loved ones, particularly around mental health. The substance use has a teen building course. Wanted to shamelessly plug those two. Nothing else there. Next slide, please. So one of the things here, this is something to highlight, is when we look at automated interventions, courses, all of this, is you really need motivation. Now, family members are motivated, which is great. Parents are really, really motivated, but don't be fooled by thinking if you build something, people will stay. They will come, but they won't stay. So just being mindful that across the type of technique, across the target of the technique, it doesn't matter. People drop off. It's called the law of attrition in digital interventions. So you have to work with it. And so a researcher named David Moore talked about supportive accountability. When you add humans into it, that significantly increases engagement, but there's also proactive ways to do it. Next slide. Proactive engagement includes emails. It includes mailings. It includes text messages. Anything you can do to put something in someone's hand when they don't have to do anything. So they don't have to sign in. They're just getting it. Next slide. And I do want to highlight this at the partnership. This is personalized, proactive mobile programs for families, and it's across need state. All people on the call have to do, or all anybody you're treating or working with has to do, is text join to 55753. It's as simple as that. You fill out a questionnaire. Based on that questionnaire, you get immediate feedback and personalized messaging over time. Nobody has to do, you don't have to do anything. It's text join 255753. And one of the things that happened is we found out it was the parent coach, our parent coaching program, and the text messaging had some of the highest satisfaction rates. And people say, well, why? Like, why, what text message? What is this? People don't have to do anything. We just finished this study. I talked about the alcohol study. This was fascinating. We offered people the opportunity after a 6-month gap at the 12-month follow-up, say, would you like to receive these text messages again? 80% of people said yes. So then we gave them all of these opportunities to sign up. You do this, you have to fill out this survey, do this, and only 7% of that 80% signed up. Then we said, well, you know what? They said yes. We're just going to auto opt them in, and they can just text stop. 75% stayed enrolled. Only 25%, even after saying yes. So these were only people who said yes. 75% compared to 7. Proactive matters. Effort matters. Next slide. Thank you. Molly's going to dive into, I'm not going to talk about it, but really in terms of the online therapy and the peer supported and clinician and peer supported work is really about relational. It's about that interaction, whether it's phone, whether it's video chat, whether it's through an individual, whether it's through a group, is that heavier relational component that skills can be supplemented through automated, even those skills can be taught as well. But it's that power of a relational experience that is so crucial that no level of automation, even a conversational agent, can mimic. And this is where the work you come in terms of the opportunity. Next slide. I'm not going to go into this. I was going to, this is all the services, remote-based services, the partnership offers, but I do want to highlight the different types of services and the different ways for people engaged is important, which is there's no one size fits all on the digital side. It's not just telehealth, for example. It's not just text. People learn in different ways. So building an ecosystem that someone can come into with multiple types of therapy, multiple channels. An example for us is when we added SMS to our service in 2018, we saw a massive increase in the total number of people coming, but we didn't see a reduction in phone calls. So what we found was this is a new model of engagement that people just weren't doing. They didn't want to call. Once we offered text, boom, skyrocketed. Once we offered Facebook Messenger, the same thing. So really highlighting that is important, and there's so many different opportunities. Next slide. And you know, the other thing I want to highlight is the opportunity for, like, we have a bilingual helpline, okay? The opportunity for that personalization to make sure you're customizing and personalizing and opening the door to different populations is crucial. It is crucial, and digital allows for that because someone can be in Wyoming and take a case. Someone can be in Florida. Someone can be in Mexico and take a case. Like this is a big shift in how we can engage people across the spectrum and engage people who normally have been marginalized and disenfranchised from traditional treatment. The other is the explosion of family-based support groups. This Santa Cruz County parent group, the number of states and counties that are doing these groups, it's amazing. So look up your local support group. You're going to find it. NAMI is doing amazing work. Smart Recovery has a family and friends program. The partnership, we have online supports for parents and caregivers. This is an unlimited resource. Al-Anon, Nar-Anon, all of these things exist. Next slide. Okay, great. So thank you. Molly's going to take it from here. We might not have 10 minutes for questions, but we'll at least have 5, and we'll follow up. So Molly.
Sure. I think one of the things I'll just say, rather than spending too much time talking about a specific case example, is just wanting to name that with each case, in the work that we do, training providers to think more systemically, to think creatively about engaging families, we want to think about multiple points of entry. We want to think about family of choice. We want to think about moving this needle. And I think if we go to the next slide, that will illustrate a little bit of how we conceptualize this family involvement and treatment continuum, and that there's value in engaging families on all these different levels of the continuum. And so when we're thinking about what this continuum looks like and how we can support providers in inviting family members to participate in the care of their loved one, we're thinking about first providing them with psychoeducation that's just general. And we have a lot of really valuable psychoeducation that we can point families to that exists, as Fred mentioned, on drugfree.org. We also want to think about how we can, as a clinician, invite loved ones, consortium and others, to participate in treatment just by getting updates about their individual loved one's treatment progress. And then when we think about inviting people to participate meaningfully in treatment, we can think about family skills training. And then the last piece on the end of the continuum is thinking about systemic family therapy. And so this table here talks a little bit about one model that we've worked on and have published published a manuscript in and are piloting a protocol in, that is one model of youth MOUD, medications for opioid use disorder service continuum, that is in parallel to the continuum I just mentioned in terms of how involved really this caregiver is. And moving along that continuum means moving away from the individual being the patient to, again, the whole family being considered the client. And when we're thinking about the different ways to engage family members, we want to think about, again, providers reaching out in terms of this tele-interventions, telehealth, outreach, engagement, training, and then recovery maintenance within this particular model. That when we're thinking about digital interventions, we can think about how to utilize them all along that continuum. We can go to the next slide. And so I'll just briefly share like a little bit about some of this model for how we support clinicians in engaging family members effectively in treatment. And then we'll talk a little bit about rewards and limitations. And then, as Fred mentioned, stop for questions and conversation. So one of the things that is really important to us to impart is this idea that clinicians need to strive for unconditional positive regard for the families that we're working with. Oftentimes, when we are struggling to engage family members in treatment, who do we blame? Sometimes we blame ourselves, sometimes we blame the families. How do we continue to strive to build a relationship, and how important it is to maintain positive regard in the context of relationship building? The first stage when we're thinking about inviting family members to participate in a teletherapy process is assessment. We really want to understand the systemic barriers that we're working with and also the family-specific barriers we talked about at the beginning. And if we don't understand the barriers that the families that we're working with are facing, it's going to be very difficult for us to effectively engage them. Particularly, we want to assess the level of hopefulness or hopelessness. We talk a lot as family therapists, we use a lot of family therapist Ken Hardy's work that talks about being in the hope manufacturing business. And when we're reaching out, we're trying to build relationship in this digital landscape with some of those challenges that Fred mentioned occur in the realm of digital services in terms of dehumanization and sometimes a risk of alienation or detachment. We want to really think about what hopelessness are we facing and how can we locate and instill some hope. We can go to the next slide. After assessment, we really want to think about inviting ourselves to be in an ally position with family members. We really want to understand more their perspective on the problem, gain more of an understanding of the different perspectives, make room for multiple perspectives within the family. And we also want to think a little bit about how they're defining the problem. When we're reaching out to folks to be involved in treatment, to be involved in therapy, to be involved in teletherapy, we want to access their understanding of both what the problem is and what some solutions might look like. And as we're inquiring about this, as we're assessing, as we're building relationship, we want to be curious about family strength as well as difficulties. We can go to the next slide. And then the sort of last stage of working to engage family members effectively in teletherapy is activating. And so if we've built a relationship, if we have a shared sense of what the problem is and what some potential systemic solutions might be, we want to shift interactional patterns to make it possible for family members to participate together in treatment. We know, again, as I said at the start of this time that I'm speaking now, that there's lots of different points of entries to working with families, to working with whole families. We understand that there is value along that continuum. There's value in working with a CSO individually. There's certainly value in working with the whole family altogether. And we want to activate what resources we see to invite more cohesion, less conflict, and families being open to participating in treatment together. Sometimes that looks like different subsystem work. Sometimes that looks like individuals coming to the table, but talking about family level strength and family level problems. But we want to provide a rationale that says, I have something to offer your whole family, and I believe each of you and your family has something to offer this healing process. Part of this activation stage for engagement is really being collaborative, I don't love sports metaphors, but I'll use one. Rather than being a referee with a whistle, a coach on the floor, kind of running up and down the court, trying to think carefully, think collaboratively with the family members about what's it going to take for everyone to come to a conversation, to come to the Zoom, to have one conversation about what's going on in your family. We can go to the next slide. So some of the things that we aim to impart when we're working with providers on effective strategies for engaging families, in addition to maintaining unconditional positive regard, we invite therapists to think carefully about status and power differences during outreach. We also want to think about how we are gatekeepers, that oftentimes by virtue of our license, we are agents of social control. And being an agent of social control and having this power differential is of course wound up with identities and, again, systems of oppression and how they impact families differently. And if we're inviting families to come to treatment, we are inviting them to trust us. And how can we take that trust very seriously, particularly in a digital space in which maybe it feels differently than that kind of cocoon of the therapy room. We believe that friendliness is fundamental to outreach. We understand that, again, being collaborative and authentically listening goes a lot further than being in an expert role. And then again, outreach, when we're talking about substance use specifically, is challenging because the culture of blame and shame faced by families. If I am encountering a family and aiming to reach out and they default to a blaming position of their loved one, I understand that that's the culture that we're all in, that's the water that we're all drinking. And so what can I do to try to dismantle that, to try to invite a spirit of collaboration and less blame and less shame there? Karen, I see your question about parent coaching, and that's a great question about what we do, and we can speak to that in a moment. But just as we're ending, we understand that working with families, CSOs, whole families digitally has some rewards and also potential limitations. The reward that I'll name is that if we're moving the needle, we can create healing that can interrupt generations of shame and blame. That oftentimes we are meeting a family that is come by what they're dealing with quite honestly, and this healing can be really transformative for generations to come. Not to oversell it, but I do really feel like that's the domain that we're in. A limitation that I'll name is that we're talking about a dual paradigm shift here. We're talking about moving from solely in-person care to this digital space. And then we're also talking about this other paradigm shift of working on an individual level to a systemic, to a family-focused one. And that dual paradigm shift, doing both of those transformations at the same time, is challenging. The last thing I'll say, and then Fred, I'll invite you to share what comes up for you about rewards and limitations before we shift to questions, is that oftentimes we do discuss a lot about the risks for family involvement. oh, there's a lot of conversation about confidentiality and about privacy, about what if somebody is de-skilled when they're working with a whole family. I don't mean to minimize at all of these risks, but I think if we're going to talk about the risks for not including family members in treatment, we need to include, if we're going to talk about the risks for including family members in treatment, we also need to talk about the risks of not including them. What happens if we don't include family members? What can go awry if family members are left out, particularly when they're really motivated to be involved? What happens if we, don't include family members in the care of young people? And so we can be curious about the risk of including, but let's also be curious about the risks of not including. Oh, thanks, Pat, for putting the parent coaching info in the chat.
Yeah, thank you, Pat. And Lachelle, you can go through those. Here are just some references. Molly and I would be happy to take questions, from anybody. And, just one thing I do want to highlight, some people are bringing up parent coaching and stuff. We used to do in-person parent coaching, and there was an amazing bond set between individuals when we did that coaching, those coach trainings. I mean, some of you on the call have been, and it's led by Pat Awesome and our partners at Center for Motivation and Change. And one of the things that happens now is we are now doing a self-guided training with Zoom sessions. And we're able to reach so many more people. We had a waiting list of 180 people, and now we're piloting this, and people are just coming in. So it's just this amazing opportunity. And at the same time, we're all missing some of the in-person coach training. We're missing that connection. We're missing going out to dinner with people after, learning about them in a different way. Then we're trying to mimic some of it, but just really highlighting that a hybrid approach to this is so important. Leverage the strengths of whatever we can. When we need in-person, when we can use digital and it makes it easy. And the goal is to make it easy. So we have a whole 4 minutes for questions. I think Molly and I can probably stay on though, but please, and any questions that may have not been answered in the chat.
There's a lot of parent questions and parenting questions. I think you may have answered them.
Okay, I'm going through the chat. Oh, are they not in the chat, Gail?
A lot of them were asking how to get training, and I think you answered that question.
Yeah, I think as Molly said, Pat put it in. So it's a free program. You just put your name in, and then when the next cohort of training. So one of the things we didn't want to do is have people, 100 people trained at once. We have cohorts of 20 people trained at a time, and we're backed up until September. So we're going to expand it, but as we have this self-guided course, we'll go. But what the course is becoming if you have a person with some lived experience, whether it's your own personal family or you've been helping a friend, you can be a peer coach to other family members, and it's providing digitally based coach support services. So it's all remote based coach support.
And
the question, there was a question around peer parent coaching. They want to know, is there a certification for this role?
It's not an official state certification, but we give a certificate of completion, and we're looking towards hopefully getting some sort of official certification, because we use a combination of therapies using the invitation to change model, the CRAFT model, motivational interviewing, acceptance and commitment therapy. We do offer a certificate, but there's no state-based training. And it looks like, someone put something in that there is a state-based if you're in Georgia.
Well, thank you, Fred and Molly. I see people are asking if this could go on for another half an hour. There was so much information. I really do appreciate this. And I hope this was an informative and helpful event. I want to thank the Partnership to End Addiction, Molly and Fred again for today, and thank everyone for your participation. A special thanks to Dr. Linda Goggin, Principal Investigator for NASTAC and the Executive Director of the National Federation of Families. And a special thanks to Lachelle and the rest of the NASTAC team for helping us run today's event smoothly. This will be our last webinar event for the series for this year. We'll be taking the summer off and returning in September with brand new series of webinars that will again be held at this same day and time. Have a wonderful summer and be safe. Please make sure you fill out your survey as you exit, and after the survey, you should get your certificate of attendance. Bye-bye now.